Yeah, I saw you got a lot of questions there.
Yeah, we always put that just in case we know that we're never going to probably get through them. But
Yeah,
yeah, we're
yeah,
we're keen.
sounds good. Sounds good. All right, let's do it.
Yeah, awesome, lovely. Okay, welcome back, sports medicine fans, to another episode of the Sports Medicine Project. Now, our special guest today is Dr. Peter Malliaras. Now, in our eyes, definitely the tendon guru, over 120 publications, and someone we have both followed and listened to for some time. I know Kelly's done one of his courses, and I still remember as a student years ago reading your review, Achilles and Patellar tendinopathy loading programs in the Sports Medicine Journal. And yeah, it's a funny kind of reflection point now getting to think about myself reading that, and now getting to talk to you about tendons is awesome. And that was back when I thought tendons actually needed to be stretched because they were tight. I was a very naive young student, but hopefully we can confirm that that's not true today. Now, I'll give a small introduction for the listeners, but you've been active in tendon research for 15 years, completed your PhD in tendinopathy in 2006, and you've been pretty busy by the sounds of it. But yeah, welcome, mate, and thank you so much for coming on.
Thank you very much, Blake and Kelly. Nice to be here.
Lovely. And so for the listeners, what's your story and what keeps you busy at the moment? I'm definitely sure it's a lot more than what I've put in my very, very short summary.
Thank you, Blake. So basically, I have been a physio for about 25 years, and I sort of worked for a bit, then got into a PhD, and that was probably a bit over 20 years ago now when I started. So I've sort of been in the sort of tendinopathy research in some format for about 20 years, and PhD came first, and then since then I've been sort of mixing practice with research at various places. I did a bit of a stint in the UK, and then since then I've been working here in Melbourne, back in Melbourne, for the last probably I think 11 or 12 years. And I sort of combine at the moment. There's Monash University 4 days a week where we've got a group of people interested in tendon research, and a lot of them are PhD students, but also some postdoc researchers. And we do studies ranging from lab studies where we look at things like trying to understand pain and some of the impairments in tendon. And then we also go right through to the spectrum of looking at more translational studies like testing treatments and trials in randomized trials. So we do sort of a spectrum of research, and that sort of is 4 days a week. Then I'm in the clinic 1 day a week, where I'm sort of seeing mainly tendinopathy patients in the lower limb. So yeah, that's sort of the mix at the moment.
Yeah, wow, that's awesome. You had a pretty long history dealing with tendons, and good to hear you see lower limb tendons. They're the best ones. I always joke with Kelly, they're the harder ones to treat. That's why podiatrists are better than physios, but we'll leave that for another topic. I did want to ask and get kind of straight into it for the people, and we're saying off there that we've got quite a lot of clinicians that listen to this, and athletes and runners as well. How would you explain the kind of functionality and basic physiology of a tendon?
Well, a tendon in its basic form is just a rope that attaches the muscle to the bone. And then you've got some tendons that are a bit more specialized that we call energy storage tendons. And that probably the best example of an energy storage tendon is the Achilles tendon. And what tendons like the Achilles do is they store energy, as the name sort of suggests. So they basically act as springs, and that mechanism is really important physiologically for runners as well as anyone that's doing any load-bearing activity like walking. Because what it will enable is it will allow the muscle fascicles to work in a very efficient range. So if you think about human movement, and you think about the thing that costs the most energy when we're moving, it's definitely the movement of the fascicles. So how much the fascicles stretch, but also how fast they stretch. So that's really costly in terms of our human movement. So we can't do many fast and large contractions back to back because we get fatigued. So what the tendon allows is for the tendon to do a lot of the straining and stretching when we're doing things like walking and running, and therefore the calf muscle the fascicles within the calf muscle don't have to strain as much. And that means that we're much more efficient. So some of the estimates suggest that up to 30% of the energy for walking is passive based on Achilles tendon energy storage and release. So it's really, really important, especially as we get older. So I see people mainly with Achilles, but as I mentioned, throughout the lower limb, and as we get older, we sort of walking is one of the key activities that we do, and you need that mechanism to be working well, but also for runners, it's really important tendon function.
Yeah, that's great. You mentioned that you work in a lab as well. Do you do some of your studies on animals as well, Peter?
We don't actually do animal studies at the moment in the lab that I'm in here at Monash. When I was at Queen Mary University, there's some people there that were doing really, really great animal research in tendinopathy. So people like Hazel Screen. I never got to work with her, unfortunately, directly in terms of some of the studies that she was doing, but she's done some really interesting work more recently looking at the interfascicular matrix, which is a part of the tendon that she's discovering enables the tendons that are energy storage to strain a lot and take a lot of energy. So she's sort of discovering some of that. But yeah, here at Monash, mainly human research. We have enough trouble with humans, so I wouldn't want to get into the animal.
I know that. Well, that's why I was asking. I was going to ask if much of the research is done on animals and generalized to humans, or vice versa, or where we know this information from. But by the sounds of it, it's probably a bit of a mix.
Bit of a mix, but we know that whenever you're looking at non-in vivo, so you go away from humans and you go to animals, or you go to cell models or other models, or even modeling work that is really popular now and common, there's always limitations because you always have to make assumptions, and that is that you can actually transfer what you're finding out in these other models and animals to what we see in humans as well. So it is an advantage to do human research, but sometimes, there's certain things you can't test on humans. For example, some of the studies they do where they, euthanize animals after they've finished certain loading protocols, you can't do that on humans. So there are limitations to human research, but generally it translates better to humans and the people we treat in clinic.
Would you say, and we're talking off air before about a patient that I just had with an insertional Achilles, and we were discussing and they were saying, I wish I could have done something to prevent it from happening, because it's obviously a long journey and it can impact on what they can do. And this person was a runner. Would you say there's any indication for screening people without pain and using particular measures, any of that kind of correlates to an increased risk of injury? Like, as an example, I don't know if it's research or it's more just what I've heard, like being able to do 20 good quality single leg calf raises to reduce the risk of developing Achilles tendinopathy, which makes logical sense, but it might not always translate out like that.
Yeah, it's a really good question. The evidence for risk factors is really quite thin on the ground. There's not much evidence for risk factors. So to be a risk factor, it sort of needs to be tested in a prospective study, which means that you need to have tested the risk factor and then follow a whole bunch of people that haven't got the problem, and some develop it, and you see if that risk factor is more common in the people that actually develop the problem. And they're quite hard studies to do because you need to follow big groups of people for a long time. So there's not many of those studies, unfortunately. We don't have a lot of evidence. Having said that, there is some. And if you take the example of Achilles tendon, there's a whole bunch of prospective risk factors that have been identified. And they're some of them are quite surprising, I guess you could say. So I think there was a study, I think it was published 2 years ago or 3 years ago by the Dutch group where Robert Jan de Vos works, and they had pulled the data on these risk factors. And I'm pretty sure there was some that were interesting, like, for example, training in colder weather was one of them from memory.
Yeah.
Things like that you
think of.
Yeah, wouldn't necessarily. We sort of tend to think of load as a key factor, and it probably is, but that didn't come out in the analysis. And I think it's because probably change in loading is really important, but no one measures that because it's hard to measure.
Yeah.
People just measure whatever volumes of load, and obviously it's quite individual. The volumes of load we can sustain at any one time. So, and obviously it's also confounded by changes in loading patterns when people develop a problem. So you don't have that in the prospective studies as much, but so load is a hard one to test. But looking at some of the other ones, so for example, fluoroquinolone antibiotics, that's a risk factor. Moderate alcohol use, training in cold weather. I've actually looked up the paper, so I'm reeling them off now.
Yeah.
Decreased isokinetic plantar flexor strength, and that's not a surprising one. So if you've got decreased strength of your plantar flexors and you change your loading suddenly, you're going to expose your tendon to potentially high loads when it's really not up for it. So that's one that is sort of one that we can address.
Yeah.
With the interventions that we use. But yeah, there's not a whole stack. There's about 5 or 6 known risk factors for Achilles, similar to other tendinopathies in the lower limb. Most of the evidence we have is for what we call cross-sectional studies and cross-sectional factors. And the problem with the cross-sectional studies is that you never know whether an impairment has developed after the onset of pain. So there's a whole stack of those. You can't really trust them.
When you say isokinetic strength of the plantar flexors, what's the figures that are coming out for that, or what do we consider to be normal?
It is a bit variable depending on the protocol. So, for example, if you do it in a knee bent position versus a sort of semi-knee bend, so 45 degrees of bend versus a straight knee, it will vary. It'll also vary depending on if the trunk is extended or you're sitting up. So the protocols vary a lot because it just depends on how much force someone can produce. But as a ballpark, I'm pretty sure that in this Matthew paper that showed that it was around about, the torque was around about, and it also depends on how fast they're moving. So it depends on how fast, because with an isokinetic dynamometer, you can move at sort of 90 degrees per second, or sometimes much faster than that as well, up to 240. So it depends on speed. I wouldn't want to guess off the top of my head, but it was a fair difference side to side. And I guess one of the ways that we look at it is how big is the proportion of difference side to side. And if it's more than 10%, then it's starting to, think about a more substantial difference. But we've actually got some data to answer that question with a different test. One of my PhD students, Igor Sancho, has just actually finished and actually been awarded his PhD. One of his studies was looking at strength measures all throughout the lower limb in people with Achilles tendinopathy, but we just compared them to people that didn't have Achilles tendinopathy and also to the unaffected side, because they all had unilateral. And what we found is that the one that was impaired the most was seated calf raise 6RM.
Right.
Yes.
I think I might have seen that. Has that been published?
It has, yeah. It was published just late last year.
I think I saw that on your Twitter. Did you share that on your Twitter? I think I've got a screenshot of that on my phone.
I did. I shared it on Twitter. I also wrote a Talking Tendons podcast about it. But we sort of found that if you've got impairments, most people can push 1.5 times their body weight. So if you weigh, say, 70 kilos, you should be able to push 105 kilos for 6 repetitions of a seated calf raise in a Smith machine. What we found is that the people who had Achilles tendon pain, and they were all runners, so they were still able to run, they were able to push more like 1.1 times their body weight. And that was by far the biggest impairment that we found. We looked at glute strength, knee strength. We looked at also standing calf raise.
Yeah.
So that was interesting. So we do know that it's impaired, but again, if we look prospectively, we're not sure if that develops after, and it probably does for some people, rather than sort of preceding the tendon pain.
Yeah, interesting. God, I'm in a bit of trouble. I weigh 100 kilos. I don't know if I can do 150 kilos calf raise. I might break my knees, but we'll see.
Well, most people, because I test it routinely in the clinic, most people struggle, even on their good side. So a lot of people are not at the level that healthy runners probably should be at. One of the problems is we don't have a lot of normative data for a lot of these tests that we do. So it was good that Igor was able to really get some data for at least that one.
Yeah, that's great.
Is that typically from like plantar grade as well, or is that looking at dropping down off a step into a bit more of that dorsiflexion?
Yeah, dropping down right down into dorsiflexion. So we didn't actually do it over a step, but with the seated calf raise, what we get people to do is just shift their heel back when they're in that sort of down position, and that allows them to get a lot of dorsiflexion. So if they slide their heel back, rather than having the tibia vertical, the tibia is angled backwards, and that sort of gets them into near end range dorsiflexion.
On that topic of and talking about kind of heavy calf training, and I know Greg Lehman and Dave Renfrew, some previous guests on the podcast, has been talking about what tendons need to get better when they're painful, and kind of the general assumption is they need heavy resistance, but there has been a study, and correct me if I'm wrong, to show that they can get better with medium and high loads, and there wasn't that much of a difference. So do we understand that tendons need mechanical force, I think, to get better, but does it need to be heavy? Does it need to be challenged, or it just needs to apply mechanical force and we get that adaptation?
Yeah, that's a really, really, really good question, because it's a complicated one. If you look at healthy tendon and how it adapts, the most important mechanism that we know about at the moment for healthy tendon adaptation is straining the tendon. So the more force you put on a tendon, the more it's going to strain, and therefore the more it will adapt. So if you're thinking about the outcome of healthy tendon adaptation, it definitely is important to strain a tendon with high force. So higher intensity is better. Now, when you're thinking about a clinical context, that's different, because now we're dealing with someone who has pain and a tendon that needs loading as well and adaptation, but they've also got pain. And what the literature shows really clearly is that in terms of improving pain outcomes and a lot of self-reported outcomes, even self-reported function disability, it doesn't actually matter if we do heavier load. So if we load them more intensely, or we do lighter load, those outcomes will still improve, and they improve it in the same way. So we've done a few studies. One of my former PhD students, Fatma Asani, she did a study where she looked at 4 different loading protocols for the Achilles, and it was just a pilot and feasibility study. But she was able to show that if you look at the effect sizes for high load and low load interventions, they were pretty similar. So there wasn't much in it. Another student, PhD student who's close to completing at the moment, Josh Nornson, he's done a similar study looking at shoulders, and he's also found the same thing. So it seems really clearly that it doesn't need to be heavy to improve pain. But we do think that heavier loading will probably improve ability to perform certain functional tasks that require higher loads, and it will probably also improve tendon adaptation. But the catch to all that is that if you look at studies, and there are only a handful that look at tendon adaptation for pathological tendinopathic tendon, you don't tend to get the same adaptive response with a stimulus that would adapt a normal tendon, healthy tendon. So
God, that makes it so complex.
It does. Yeah. It sort of makes your brain hurt a bit, because you sort of think you're doing all the same things, but the tendon doesn't actually adapt. Maybe we need to do longer duration interventions. Maybe instead of 12 weeks, like healthy tendon, we need to do it for, 26 weeks or a year. Maybe we need different interventions for pathological tendon. We just don't know yet. But or maybe the outcome measures that we're using are not good enough. So the main outcome for tendon adaptation is the amount of stiffness of a tendon. So it's the amount of stretch for a given force. And that outcome might not be sensitive enough to show different adaptations that are going on in the tendon, not on that sort of global stiffness outcome that we're using. So it's a complex area, but generally as a clinical rule of thumb, to be able to provide some clinical guidance to people, and what I tend to do in clinic is I will sort of adhere to the principle of you do want to do some loading that is higher intensity. At least 1 or 2 exercises of getting up to higher intensity is probably a good principle from a point of view of adaptation of the muscle and tendon. It's probably the way to go, even though you don't necessarily need to do that if you are just focused on pain as an outcome.
And is that, when you say higher intensity, is that the rate of loading, or in regards to strength, or both?
High intensity would be sort of greater than 70% of MVC if you're doing isometric, or greater than 70% of 1RM. So you're looking at fatiguing them, by about 10 reps or something like that. Yeah.
Wow.
And then
it's funny. Just when you think a little bit, you don't really.
I mean, we kind of touched on this throughout that, Peter, but why don't we rest tendons? I know previously we used to think rest was the answer, and now we know that loading is probably more likely the answer. Do you think that there's any possibility it could go full circle and we could end up wanting or thinking that we need to rest tendons again, or do you think there's enough evidence to support loading for improving tendon adaptation?
Yeah, look, that's a really good question. Interesting area. So if you go back to the 70s, we would say to people, you've got to rest because it's inflamed and it will settle down. At that time, they were also cutting out bits of pathology in the tendon because they thought it was as simple as if you just take out the pathology, the tendon will feel better. So we had a very simplistic view that was based around pathology equals pain. The pathophysiology is inflammation, you just got to rest it, which we know is not right now. But I think we have got now into a period where we want to be active in our interventions. And the main reason for that is we know that if you're not active and you stop being active, your pain can actually get worse rather than better. So you go into a cycle where you become deconditioned, tendon becomes weaker. And a lot of these people also have psychological sort of associated factors like, poor self-efficacy and high fear avoidance. So that type of patient, it should be encouraged and reassured to be active regardless of a little bit of pain, and that they'll probably do better if that's the case. But there is, as you've alluded to, a limit to the sort of mantra of we should be active regardless of what's going on. We do need to be careful. Sometimes I think with the situation where you've got someone who's really, really irritated and flared up, and they do need rest, in inverted commas. And rest might be just reducing loads really substantially for a certain period of time. So that still is important for some people, depending on how much pain they have with the day-to-day things they're doing. And then you've got other people who, really are sort of, you might be doing exercise and rehab with them and they're just, flaring up or having a pain response that is beyond what would be acceptable. And that, the thing that we tend to call acceptable is an increase in pain for a short amount of time after loading or some activity is okay. And those people, again, you might need to adjust. So it's sort of a constant process of the way that I sort of try and explain it to patients is you've got the ability of the tendon to take load And that could be day-to-day walking plus running plus the exercise we're doing. And then you've got the amounts of that loading you're doing. And you've just got to find the balance between those two. And sometimes it involves rest completely. Sometimes it involves a trade-off. Sometimes it involves no rest and continuing or even increasing the amount of loading they're doing, depending on how they present. So if they present with a lot of pain, you're probably going to reduce loading. If they present with not much pain, some people present with not much pain, but not much activity either because they're fearful. And then it's reassurance and trying to get them active. So it really does depend on where their starting point is.
How do you explain, and you've definitely answered it there, like when people talk about, tendons becoming irritable, and we're very much, I know Kelly and I are very similar in the clinic, trying to de-threaten the pain and saying it's probably not the best measure of the tissue health when the tendon's been painful for a long time. And I'm imagining, an Achilles tendinopathy that's been sore for 2 years, as we start to do more, yes, it can be sore, but it's probably more related to the sensitivity than real pathology in the tendon. Do you find that's the case, or how do you explain that to patients when they are a little bit fearful and they're worried that they're doing kind of more damage, and it's okay to have a little bit of pain with the rehab?
Yeah, look, I think just simple messages like making sure that they're clear that it's not, so pain is not a sign of damage or further injury. It's okay to feel a little bit of pain, and then that might be enough for some people. So just the reassurance that it's okay to feel pain with certain activities, you're not going to rupture it, it's not going to get worse in terms of the pathology that's there. That could be enough for some. Other people, you might go down more of a pain neuroscience explanation where you sort of then explain further about, it is okay to load a bit because we know the pain is not related to structural tearing or damage. The pain is probably related to a biochemical response in the tendon, which is separate to what's going on from a tissue point of view. It's more of a cell response, but also it's influenced by so many other factors in their day-to-day life, like how much they sleep and how attentive they are to the pain and fear and all these other factors that we know about in the biopsychosocial model. So, so then just you might go, more towards a pain neuroscience explanation for some people. If they sort of are thinking, if you're thinking this person wants a bit more, or they'll benefit from that level of explanation. So it can be quite individual, but I find most people are pretty reassured when you say to them, look, it's completely fine to have a little bit of pain, you're not damaging it. It's sort of an intuitive thing, I guess, for most people where they find that level of detail is enough. You don't need to go necessarily to pain neuroscience education.
Yeah. Kelly, you're looking at me.
I just had one question. You mentioned the biochemical response within the tendons. Could you elaborate on that? That's probably just me being
surely that'd take like 5 hours, I'm sure.
No, it's quite simple because my understanding of it is quite simple. I can tell you I'm not a cell level researcher, but there's a lot of stuff that's been looked at in terms of the cell response. And generally and there's a really good paper written by Neil Miller and his group in Europe, the UK, about the sort of pathophysiology understanding at the moment. It was in Nature Reviews. But basically, the thinking at the moment is that you've got a whole host of cell changes. So you've got all these cytokines that change in terms of their levels within a tendon, and they're basically driven by probably excretion and from the cell, but also some of the local nerves that are in the tendon. So things like substance P, calcitonin, germinated peptide, but also growth factors like vascular endothelial growth factor, and they cause changes in immune system level, but also neural function within the tendon, and they may then contribute to some of the pathology and pain changes. So the thinking is that you've got a whole host of really complicated sort of cell and neural and immune changes that happen within the tendon, and that sort of sets up that environment of pain and sort of change in the tissue itself.
Mm.
And is there something in that that leads us to understand why pain is typically after loading?
There are a few theories about that. And it could be that you have a delayed response from the tenocytes within the tendon, and they then start to signal, and you start to get changes in pain. So there are a few theories, but I don't think we have anything definitive about what's going on with that pain behavior.
Ellie, you're asking some tough questions. That was a good question. I feel bad now. I've just got a pretty simple question, but something that we talk about a lot and learn about, especially in the podiatry profession, is kind of a big no. You never do it. You never inject a tendon. But asking it yourself, have you seen, and when you've managed them over the years, like, do you think there's any indication for injectables, and whether that be PRP or cortisone or prolotherapy for tendons at any stage, and thinking end of the spectrum of someone that they're irritable, they're really struggling to move and really can't do much at all? Is there ever a stage where that might be an indication?
Yeah, look, I sort of have to answer yes to that, because I'm currently leading a trial funded by NHMRC investigating an injection for Achilles tendinopathy, and that's the high volume injection. But I think injections generally, if you look at the overall, there's probably three main ones. There's steroid injection, there's PRP, and there's also the high volume injection, which is high volume of fluid with some steroid and local anesthetic. And none of them have got, I think it's fair to say, a strong evidence base supporting them. So I think that's why people have, I guess, gone away from injections, or not really been keen to go there unless it's a real last resort. Having said that, they are really commonly used, and if you've got someone who's failed lots of interventions, they're very, very commonly recommended at that point. My personal view on things like steroid or PRP or even high volume is that for the right person at the right time, they're probably all possible as something you'd recommend. So my practice would be to try and inform the patient about the risks and the benefits for each one. So we know that with steroid, there is strong evidence for short-term benefit, but there are question marks over longer-term harm. So in the longer term, you might actually get a recurrence of your pain. With PRP, we know the strong evidence that it doesn't work compared to placebo. But even when you tell that to some patients and they've tried everything, because anecdotally some people get a response, they might have had a friend or someone they know that's got a response, they might be still keen to try it. And then you've got the high volume injection, which is still developing in terms of its evidence. So there's not really any good trial evidence. As I said, we're doing a trial at the moment. We've recruited 192 people with Achilles, and we'll publish the findings of that over the next 12 months. We don't know the findings yet. We haven't looked at the data. We're still waiting for 12-month follow-ups to come in, but that will help us in terms of how we sort of think about injections. But still, we don't have a strong evidence base for injections. So I don't think they should be considered as, never do an injection. But I also think they are overused massively in terms of clinical practice all over the world. And I think it's because patients perceive them as something that might help them and be easy to do, rather than what we generally recommend, which is really hard to do, and that is exercise over several months.
Yeah. Have you found, so where I work with a bunch of sports doctors and sports physicians, and injectables are a common practice. And like you said, at the right time, it can really change people's lives. And I've seen people where it's completely taken away their pain. Now, obviously, that's not everybody that has an injection, but seeing it does work in those cases. I looked for a long time to try and find any research that having cortisone to the Achilles increases your risk of rupture, and I couldn't find anything. I only heard anecdotal stuff from the doctors and other people. Have you heard anything about that?
In terms of rupture for steroid?
Yeah, like having a rupture after having an injection, like it increases your risk significantly.
Yeah.
Yeah.
So I have seen a few people who had steroid and then ruptured after, and
Yeah.
pretty quickly after. And it does happen with steroid. I think the key factor is where you put the steroid. So if you put the steroid into an Achilles tendon, you massively increase the risk of rupture. If you put it around the tendon, my anecdotal experience is that risk of rupture is much lower.
Oh, yeah.
I've seen people who are young in their 20s have a steroid injected into the Achilles tendon and then they rupture.
Yeah.
These are not people who are old and got degenerative tendons. They got relatively okay, it's still pathological, but not like you get when you're 60, but they still rupture. So I think into the tendon, it should not be done at all, but around the tendon is probably a different story, and we just don't know enough about the long-term effects. But my impression is you can still get ruptures, but it's much, much, much smaller risk than into the tendon.
Yeah. And talking about kind of those more passive modalities, and assuming the goal is for someone to get back to their activity or their meaningful activity pain-free, where do you find passive modalities sit in relation to tendon rehab? As an example, like dry needling and acupuncture and shockwave and massage. And I also imagine there's lots of ways to answer it, but does it change in regards to the specific tendon or the modality, or what's your thoughts on those?
Yeah, look, I think they probably have a place, but a very small place. If you go to the evidence and answer it based on that, again, the evidence is really not very strong for any of those interventions. Arguably, shockwave therapy has a better evidence base and a developing evidence base compared to some of the other ones, but still not really a strong evidence base. If you look at it from a, say, clinical, practical point of view, adding those interventions could be helpful for pain in the short term, could be argued, even if that is partly a placebo effect, that's fine. But the trouble with that is how much are you cutting into your time to do other interventions that we know are effective or possibly more effective? So, counselling the patient, education, transferring self-management to the patient, and then setting them up with a sort of activity and exercise advice that they need. So my preference would be to try and fit all those things in. And I don't find that I generally have time to do a lot of other things once I've done that. But yeah, as I say, a small part of treatment, it could be acceptable.
Yeah.
Yeah. I guess that it comes down to the goals and what the patient wants. If they're wanting to get out of pain for a short period of time, then that's when maybe you might be able to help them out with some of those passive modalities. But I'm not convinced that dry needling is going to help them to get back to things like running without a lot of emphasis on the importance towards, loading and exercise. Yeah,
I absolutely agree with that. I think it's good to take a patient-centered approach, and if the patient is really keen to get an improvement of pain in the short term, then it could be something to try. And I do use shockwave therapy, and that is something
awesome.
You can get a short-term benefit for some people with shockwave therapy. So it's definitely, I think looking at the patient's goals is important.
Yeah, we use that and see, and it's hard and I always posture it to the patient. Same with, because we see lots of heel pain as well. we always posture it that it's probably not the shockwave in isolation that's getting you better. It's a combination, but it's always hard to know, is it the shockwave or the fact that you just now have been doing your rehab for 4 weeks and that's why it's improving, and you slept well and did everything else right? It's always hard to know.
Yeah, I agree. It's difficult in the clinical context.
What do you think, like for the very general common presentation, somebody comes into the clinic with a sore tendon between that kind of 3 to 6 month mark, wanting to get back to activity, and speaking more specifically to the rehab and understanding, I guess you meet the patient where they're at in regards to kind of the rehab continuum, but what do we think the tendon generally needs? I know we touched on it a little bit before, but I know for, Achilles tendon, we think, isometrics and then isotonics and then slower rates of loading and then faster rates of loading and then energy storage and release. Is there a kind of, I guess, a tendon spectrum or continuum that you generally follow?
I think probably if you look at what you've described there is probably a comprehensive approach and pretty much the way to go. And you want to look at the person as an individual, understand what type of impairments they have. So I look at exercise as a way of, I guess, first and foremost, empowering the patient to be confident with loading. So that might be enough for some people. And then you might just be doing some really, it doesn't have to be too specific, it can be quite general loading just to improve confidence. And it might be based around some of the things they find difficult or find threatening and not necessarily following exercise adaptation principles. Then you have other people who have got more impairments. So they've got strength impairments and hopping impairments and other problems. So for those people, you might do more specific interventions with specific outcomes, looking at trying to address some of those specific impairments. So then you might go down more of a heavy, slow resistance approach, which is a little bit more geared towards adaptation of the muscle tendon unit. So then following that with other interventions like hopping, and before you start then looking at return to running and sport. So I guess it sort of does depend on the person. It's also dependent on where they've got pain and painful activities. So yeah, I think probably looking at exercise more broadly as a way of just building confidence, addressing pain, but also then looking at adaptation. So not everyone needs to go through a very comprehensive, loading program where they do everything. It can be quite tailored and individualized depending on the person.
Yeah.
That's cool. Could we talk about the difference between reactive tendons and degenerative or persistent presentations, and sort of including like the pathophysiology and the differences that you might see in rehab?
Yeah, for sure. Yeah, look, it's so the Jill Cook and Craig Peter model from 2009. That's really a popular way of categorizing tendons. So people look at reactive as, very, very painful. They sort of, very irritable. They flare up for days after you do certain things with them, whereas degenerative is more, not as irritable. There's still pain, but sort of background level. They sort of also then relate that to the pathophysiology and the pathology within the tendon. So reactive might not be as progressed, degenerative is a little bit more progressed. And then there's also reactive on degenerative presentations where you've got acute sort of flare-up of pain, but the tendon isn't, so the tendon's still degenerative with that pain presentation. The problem, I guess, with that model is that it's very hard clinically to assess pathology unless you've got ultrasound. And even when you do have ultrasound, it's not really clear and you can't really detect those types of presentations. So it's really clinically you're driven by pain, and you're looking at reactive as very irritable and the degenerative as not as irritable. So really pain is the guide clinically. And I go based on things like how much aggravation do they have after certain activities, like stretch, shorten, cycle activities like walking and running. How much pain do they have with those activities when they're doing them? So those types of things can guide how irritable they are and then what you do with them. So that's sort of how to apply it clinically. So it is a really good model, but I think you can sort of simplify it down and just call it irritable pain versus not irritable pain, which is sort of how I sort of deal with it clinically, where you haven't got the luxury of knowing what the pathophysiology actually is.
And do you think it changes rehab if you're dealing with a reactive versus a degenerative tendon?
Yeah, it's a good follow-up question. I thought you might ask that one.
You're on fire today, Kelly. Far out.
I don't think it does too much. So I think we just don't know. Clinically, you're dealing with pain and you sort of want to get them tolerant to pain. To be able to load and do the things they want to do. I don't think we know that, if you've got a degenerate tendon, you've got to do this, this, and this with it, as opposed to another tendon. I think what we should be thinking about is more broadly. We should be thinking we've got a tendon that's painful. We've got a tendon that's probably not at the level of health that it should be at. And the person is expressing pain because of that. And that could be for all the biopsychosocial reasons we talked about. So we should do something to make the tendon more healthy, like the high intensity loads we talked about. But we also should consider the whole person, and really sort of loading and other factors that we can also modify to maybe help their pain. So I think thinking about it as degenerate and reactive and doing specific things, I don't think we have any basis for that. But thinking about it as you want to make the tendon more healthy, because we've got evidence that it's not coping, and the evidence for that is just the pain that it has, I think that's a good way to go.
Evidence that it's not healthy. I like that.
Keep it simple.
And then I have one more question.
Yep.
For you as well, which you mentioned imaging before, and I just had a flashback to your course that I did maybe a couple of years ago, where you were talking about ultrasound for glute tendons and the difference between like being able to differentiate between a glute tendinopathy and a glute tear, and they looked at a bunch of different radiographers, and there was just so much variability amongst what they thought the diagnosis was. Is that still the general consensus, and is that just for glute tendons, would you say, or all of any tendon throughout the lower limb in particular?
Pretty much for every tendon, yeah. So there's we actually did a consensus process. When was it? Back in 2018, we got together a group of international tendinopathy experts and researchers, and we sort of met up and tried to develop consensus about various things like the outcome measures we should use, and even things like terminology, what we should be calling tendinopathy. And one of the sort of, I guess, items that we wanted to discuss at that meeting was imaging, and whether we can reach consensus about, how to image, what we should be imaging, how to sort of grade imaging. And that sort of fell apart because we realized that it was just too difficult and we didn't have the right expertise in that particular meeting. But I think it is it's a real challenge. I think looking at imaging, I had a patient yesterday who came in and he had an Achilles mid-portion problem. He was 67 years old. He's got typical really thick tendon, and he was diagnosed with a 3 centimeter tear within the tendon. And when I looked at it under imaging, it was clearly a tendon that was having a sort of heterogeneous echogenic pattern. And what I mean by that is it was just black little lines throughout the whole tendon, basically, that shouldn't be there. So calling those a tear is, I think, a bit of a stretch, because we don't really have the evidence to know that that's a tear process and the patient thinks they've suddenly torn their tendon. So that's an example of just how people just are calling things pretty much whatever they want. in the tendon, and we've got no consensus about what a tear is or how to grade tendon pathology at all, aside from the size of it, because that's easy to measure. So it is a problem, and we probably will get there, but it's going to be a tough road to bring everyone along for consensus of imaging, given how much diversity there is out there in understanding and opinions at the moment.
Do you ever have you had cases where you've put someone in a cam walk or a boot ever for a tendon injury, and specifically talking about an Achilles or a peroneal or a tib post, or is that only in a ruptured case?
Yeah, look, even the guy that I'm talking about last night, like he came in, and it was a really interesting case. He had a total knee replacement 2 months ago, and he developed the Achilles problem 2 months before he had the total knee replacement, and it was on the opposite side, so it was clearly related to favouring his other side. And he now, even those 2 months post a major operation, the Achilles pain is much worse than any problems he's got with his knee. And he, when he was walking, he had severe pain just walking, and he only walks a few hundred meters per day. So someone like that, you would consider getting them into a boot just from a pain point of view, just to allow the tendon to recover whilst he's doing exercise out of the boot every day, just for the walking. So we did talk about it. He was resistant to it, so we went with 2 heel wedges and really good footwear. So he's going to go down to he came in with really crappy, you'd probably like this, Blake, and you've seen this quite a lot, really floppy, sort of, non-supportive shoes. I think they were Skechers.
I thought you were going to say he was in like the Vivo Barefoots or something like that with the little
no,
toes around it.
Not quite, but sort of the next step from that, he had Skechers on. So they were basically offering no support whatsoever, no heel wedges in there. So I got him to, he's going to go down and get probably some Hockers or something today with 2 heel wedges, but I've given him the heel wedges, and he's going to take them down to the shop so they can fit him at the shop with trainers that fit without his heel coming out the back of it. So, and even yesterday with his Skechers, with the heel wedges, his pain went down pretty dramatically just with the heel wedges in. So you can achieve a lot with just some of those interventions, but for some people, if you can't, and what we said yesterday was, if your pain is still pretty bad next week, we'll consider a boot for a week or two. That's reasonable.
Yeah, you did pretty well. That's half my podiatry degree, learning how to put in heel wedges. You're halfway to becoming a podiatrist. I did want to ask around the follow-ups and, being a clinician for your amount of time and seeing patients for several years with these tendinopathies, and knowing that, it seems to be the biggest risk factor we have for any lower limb tendinopathy is having a previous tendinopathy of the same nature. Do you find, and I always posture to patients now when it's the last appointment and I'm about to discharge them, and saying it's probably likely or it can happen where you may have a flare-up in the future. I've just seen that with people with tendinopathies, and especially Achilles tendinopathy in runners, and trying to give them all the self-management strategies. Do you see the ones that you manage with any lower limb tendinopathy, even once they're back to 100% and you've discharged them, sometimes they do get these flare-ups over the years, and they might give you a call, and usually it's okay. It's just something that the tendon is now a little bit more sensitive than what it was?
Yeah, without a doubt. There's definitely, and there's even evidence out there, it's from football, suggesting that the rate of recurrence is really high. So a lot of, people do suffer recurrence really commonly. And I think what you're doing is spot on to say, look, basically musculoskeletal injuries are a bit of a revolving door, all of them. So, OA.
I like that one, revolving door.
OA, tendinopathy, whatever it is, it is a revolving door. So you've got, and you're also right that is an established risk factor. So if you look at Achilles tendinopathy, one of the risk factors is previous injury to that leg. It doesn't even have to be a tendinopathy, just an injury. And so I think, sort of telling them that it probably will come back at some point is probably important as part of their, education, I guess, ability to stay with the exercise program, or at least do something to mitigate their risk, like being really careful with their loading. So it's part of the process of setting them up with longer term strategies to be able to cope with that, but also not be too surprised. But you do have people, especially when it's a really bad one. So I can remember quite a few people along the way where they've had a really bad tendinopathy that set them back for years. And then they get it better eventually. And then they get the other one that comes on the other side, and they start to panic because they think they're going to go through another few years of the same stuff.
Yeah.
Often it's not as bad because they've got the education. They're not doing the same things they were doing before. So often it's not as problematic for them, but they tend to panic because they think they're going to go down the same path. And spend thousands of dollars and have to see all these different people. So it can be a little bit scary for them.
Yeah, I want one final question, and I did want to quickly touch on your courses as well. But would you say there are any factors that clinicians should be aware of and maybe make aware to their patients of what can affect the rehab time? Like, I usually go through something of the lines of, it's in the lower limb, you're putting a lot of stress to it, even when you're not doing activity, just when you're walking and moving, and that can kind of play into it not getting better possibly as quick as probably what we think it should. But is there any factors that you think influence tendon healing that clinicians aren't aware of?
Yeah, I think all the sort of key risk factor groups. So things like metabolic health. So, for example, if we go back to this patient from yesterday, he weighed 117 kilos, and he was probably I'd say 5 foot, 7 or 8.
Yeah.
So he was definitely obese. He had hypertension. He had cholesterol. He'd been on statins for 30 years. So those factors are really going to make a huge difference in terms of getting someone better. So what I said to him and what we planned to do, there were 3 things we did as intervention yesterday. One was very basic loading, which is just an isometric in standing. And he could only do it double leg because he wasn't able to do single. And then we also did the heel wedges that we talked about. And the third one was get him to an exercise physiologist, or at least considering that, to do 2 or 3 sessions a week of physical activity, and sort of look at his body fat and how that's changing. So I sort of said to him, look, if you do one or the other, you're probably not going to have a good outcome. But it's also things like hormonal factors for females. It's things like really severe other injuries where they've had long-term weakness and issues that they've dealt with that would also be a factor. So I'm seeing someone at the moment who's got an Achilles problem, but it's on the background of a very, very bad knee PFJ issue that she's had for a long time, which still isn't really where it needs to be. So there's a whole stack of factors that we can probably address as part of treatment. Then there's people that are just genetically, I think, predisposed to having a tough time as well, and they often have bilateral issues. Sometimes that's explained by inflammatory problems, sometimes it's not, and you just have to then be conscious of that as well. And then there's a whole and then there's another group of people who don't get a good outcome, generally because they don't adhere to the things that we tell them to do. So the ones that don't really like exercise, and that's where you can also, going back to the conversation we had before about adjuncts, you can start to think about shockwave or other things for people who are not so good at doing exercise or don't want to do exercise as well.
Yeah. Great. And lastly, so how can people find you? I put this, and we will put this in the show notes, but your Instagram handle, but I know you've also got, as Kelly mentioned, she's done one of your courses before. You've got a whole website, Tendinopathy Rehabilitation, and all your courses are online. Are you doing any in-person ones as well to find your information?
Yeah, look, thanks for asking, Blake. I'm doing so this year we've got a few courses booked or ready already. We've got so it's tendinopathy.rehab.com, and they're on there, but also they're on sort of all the Twitter. I've done some posts about them, but I think we've got so far Sydney in April.
Oh, cool. Newcastle, not far north. Have a look at that.
Yep. Sydney in April, and then we've got Melbourne, and then Perth at some point over the next few months. So
Okay.
yeah, we've got 3 that are booked so far this year. So yeah, it's basically just a bit of a deep dive into assessment and management.
Yeah, that'll be awesome. And I'm pretty sure it says, I'm looking on the website now, and it says if you can do 1.8 times your body weight, you get 20% off. Is that right? For a car race.
That's good. I might incorporate that. It's not on
Yeah,
there.
it's something ridiculous like 3.8. You just have all these people training for like 8 months.
Send us a video of you doing 2 times your body weight, and you get half price. That's not a bad incentive.
Yeah, that's not too bad. Disclaimer: if it ruptures, you can't sue though.
I like it.
Yeah, that's good. All right, Peter, we'll let you go, mate. Thank you so much for coming on. It was great. I mean, been looking forward to this for several months, and I know Kelly and I spent a lot of time with the questions, and we narrowed it down from about 30 or 40. So I really appreciate you taking the time and helping out, and we'll definitely link all your stuff in the show notes as well.
Fantastic. Thank you very much for having me.
Thank you.
Thanks a lot. Thank you for having me.
See you later.